Hi, this is going to be the first of two videos talking about the cranial nerves. And this video is going to focus on cranial nerve 1 and the cranial nerves that affect the eye, so that's 2, 3, 4 and 6. So there are some key things to remember about the cranial nerves, and one of the things you should know is their names. So we have our olfactory, optic, oculomotor, trochlear, trigeminal, etc. But the other thing you want to be able to work out is which ones have sensory supply, which ones a motor supply, and which ones play a role in both. And there's a helpful mnemonic for remembering this, which is some say money matters, but my brother says big brains matter more. And some of the words in that are interchangeable. We also have the skull foramina, and these are at the bottom of the skull, and it's helpful to be able to remember what enters and exits through each of the holes so you can work out where problems might be if you're seeing problems in that cranial nerve. So we have at the front our cribriform plate, which is where our cranial nerve 1 olfactory nerve passes through. Then our optic canal, where we have our cranial nerve 2 optic nerve coming through. We then have our superior orbital fissure, where our cranial nerves 3, 4, 6 and 5A pass through, and 3, 4 and 6 all pass through there because they have to get to the eye. And then we have our foramen rotundum, which is this round one for cranial nerve 5B, and cranial nerve 5C through the foramen ovale, which is oval shaped. We then have our foramen spinosum, which is where our middle meningeal artery comes through. Next we have our carotid canal and foramen lacerum, and this is where our internal carotid artery enters and then comes through into our skull. And then we can move back to our internal acoustic meatus, where we have cranial nerves 7 and 8 going into the temporal bone. We then have our larger jugular foramen, and this has cranial nerves 9, 10, 11, as well as our internal jugular vein, and our hypoglossal canal, which sits just next to the large foramen magnum, which has our brainstem and spinal cord coming down. So our cranial nerves. First we've got our cranial nerve 1, and this is called the olfactory nerve, and its job is olfaction, which is smell. And as we said, it passes through our cribriform plate. It doesn't have a nuclei within the brainstem, and that's because it sits above the level of the brainstem. So our sense of smell comes from our olfactory epithelium, which sits at the top of our nasal cavity, and it then travels through our olfactory tract, and this then travels to the uncus of the temporal lobe, which is on the medial inside part of our temporal lobe. And this is abnormal for a sensory pathway because it only has 2 neurons. So we have our olfactory tract going back to our thalamus. Not going to our thalamus. And it's important to note that this does sit close to the amygdala. And this plays an important role in memory, and that's why we often have strong memory associations with smells. Next we have our optic nerve, which is our cranial nerve 2, and this has the function of vision and passes through our optic canal. So our visual system first comes back from our retina, and this then synapses with our optic nerve. Our optic nerve then travels back to our lateral genicular nucleus of our thalamus, where it then synapses again to our third order neurons, which travel in our optic radiation back to our primary visual cortex, which sits at the back of our occipital lobe. So our eye is split into 3 layers, and the retina is the primary area for our sensation of our vision. And we have our fovea, which is our point of high visual acuity, and this is because it's got a very high number of cone cells. And then we have our optic papilla, which is our blind spot. And this is because at the point where our vessels and our optic nerve enter, there aren't going to be any of our rod or cone cells, so we have no vision at that point. So our retina has these receptors, which are our rod and cone cells, as you can see here. These that receive the light and then transmit to our bipolar cells. Our bipolar cells then pass the information on to our ganglion cells, which form part of our optic nerve, and our optic nerve is then our second order neuron that runs back. So this diagram here shows our visual pathway. And it's important to remember when you're looking at the visual pathway, you've got this part of your retina and this part of your retina. So you've got left and right, and that's on both eyes. But because of the way light enters the eye, information from the right-hand side of your visual field will come across and hit the left-hand side of your retina. And if it's on the left-hand side, it again will cross over. And the same will happen on this side. So the right-hand side of your visual field hits your retina on the left-hand side. So there are a few different places that we can have lesions. If we have a lesion here, then this will completely cut off one eye and damage the optic nerve. So this means that that eye will have a complete loss of vision. Then we come back to our optic chiasm. And this is where we have to remember that the left-hand side of our retina has our right-hand visual field. And that's because on the outside, the left-hand side of our left eye, for example, will travel along here and then carry on the left-hand side on the outside, whereas the right-hand side of our visual field will cross over at this point. And on this side, our medial part, which is our left-hand visual field, will cross over, and our right-hand retina will stay on the outside. So this means that our retinal fields from our right will both end up on the right, and our retinal fields from the left will both end up on the left. So if we have damage at this point where the optic chiasm is, where our retinal fields are crossing over, then it's only these middle fibers which are crossing over that will become damaged, which means that we'll have loss of this right retinal field in the left eye and our left retinal field in our right eye. So that means that in our left eye, we'll be unable to see the left-hand side, and our right eye will be unable to see the right-hand side. So this means that we'll lose the outsides of our visual fields, and this is called a bitemporal hemianopsia. We can also have lesions which just affect the outsides, and these are a lot less likely to be bilateral. So you'd expect only one side to be affected at a time. But if both sides are affected, then we'll lose this part here and this part here. So they both supply the middle part of our vision. So we'll have what's called a binasal hemianopsia. So we then travel back to our thalamus, where we'll synapse at our lateral geniculate nucleus. We then, from our lateral geniculate nucleus, have our optic radiations. So from our optic radiations, these fibers will fan out, and we have this splitting into an inferior part and a superior part. Now, our inferior part will carry the information from the superior part of our visual field, and the superior part carries the visuation from the inferior part of our visual field. So much like all the other information so far, it's all crossed over. So the inferior fibers, which carry the superior part of our visual field, travel through something called Meyer's loop, which travels into our temporal lobe. And if we have a lesion, therefore, in our temporal lobe, that will damage our inferior fibers, so it will damage the superior part of our visual field. And if it's on our right-hand side, well, we've established that our right-hand side is carrying our right retinal fields, which is the left-hand side of our vision. So we'll lose the superior part of the left-hand side of our vision in both eyes, and that's called a left superior quadrantenopia. If you have damage to the whole of our, and the same thing can happen on the superior visual fibers, affecting the inferior part of our visual field. And this would be a left inferior quadrantenopsia. If we have damage to the whole of the optic radiation, then this will mean, or it can be along here, then this will damage all of the left-hand side vision, because this is all of our right-hand sided retinal fields. So we'll have damage and loss of our left-hand side vision. And then if we have damage at this posterior part, then again, we'll have loss of this left-hand side of the vision. But you might have something called macular sparing, and that's where you have this small central section which is still able to function. And this is because of the way that the fibers fan out at this point, and the calcarine sulcus, which is our primary visual cortex, which has the center of our visual field, is often spared. So now we're going to move on to our cranial nerves that move our eyes. So we'll start with our cranial nerve 3, which is our oculomotor nerve, meaning eye movement. And this has the function of moving 4 of our 6 muscles that move the eyes. So this is our medial rectus, superior rectus, inferior rectus, and inferior oblique. We then have our cranial nerve 4, which does our superior oblique, and this is called our trochlear nerve, and our cranial nerve 6, which is our abducens nerve and does our lateral rectus. So if we have an eye, then it will have one muscle on each of its 4 main sides, one on top, one on the bottom, one on its left, and one on its right. So the one on the top is called our superior rectus. And if you think of someone holding a ball between their 2 hands, and then if they, one on the top, one on the bottom, if they pull their top arm back, this will roll the ball backwards. So if it had an eye on the front, this would make it look up. If you just pull the one on the bottom, it would make it look down. Similarly, if you've got your hands on the sides, if you pull the one on the left, it will make it look left. And if you pull the one on your right, it will make it look right. So this means that our superior rectus, inferior rectus, medial rectus, and lateral rectus all make the eye move in the direction that the name suggests. We then have our inferior oblique and superior oblique, which have slightly more confusing movements. So they essentially don't move the eye at all in its normal position. But if you move the eye laterally, so this is using our lateral rectus, meaning that the eye is in its abducted position, then the superior oblique is unable to pull the superior rectus, is unable to pull the eye up effectively. So the inferior oblique, which sits at an oblique angle, which means it's diagonal, is able to get a better hold essentially on the eye and can cause it to look up. And the superior oblique does a similar job, but makes it look down when the eye is looking inwards. So we also have some muscles which move the eyelid. So for lifting up the eyelid, we have our levator palpebrae superioris, which is controlled by cranial nerve 3, and we have our superior tarsal, which does less of the job, and this is a sympathetic controlled muscle. So when we have a patient with Horner's syndrome, which is loss of their sympathetic nervous supply, they have a partial ptosis. And this is because you have loss of the supply to superior tarsal, and that means that the eyelid will droop down slightly, but not all the way, because you still have the levator palpebrae superioris keeping it up. Causing the eyelid to look down, the eyelid to close, is controlled by something called orbicularis oculi, and this is controlled by cranial nerve 7. The way I like to remember this is to think of the function of cranial nerve 7, which is muscles of facial expression and movement of those. So if you have a really, really big smile, it's common to close your eyes, because if you're grinning really tightly, you close your eyes in excitement. A big smile is facial expression, so cranial nerve 7 closes your eyelids. So now we have a few different things that are going on that we have to remember about the eyes. So first we have the pupillary light reflex. So if you shine a light in someone's eye, the first thing that they'll do is hit you, but after that, their pupils will contract. And you want, if you shine a light in the right eye, both of their eyes to contract. So if you shine a light, this will be received by the retina. And this is our left eye, and this is our right eye. And you shine the light in their left eye, the retina will receive that information, and it takes it back to the pretectal nucleus. The pretectal nucleus then sends information to both the left and right Edinger-Westphal nucleuses, which carries information back along our cranial nerve 3 parasympathetic part to the ciliary sphincter, which causes your pupils to constrict. And obviously this works in the same way. If you shine light on the right hand side, it goes to the retina along cranial nerve 2 to the pretectal nucleus and communicates on both sides. So you get this constriction on both sides. So next we're going to talk about the accommodation reflex. And this is in order to look at something close to you and focus on it effectively. So first you want vergence, and this is causing your eyes to come together and both look medially. Then you want your pupils to constrict so you can focus more effectively, and you want your lens to fatten to allow the greater refraction of the light to allow it to focus on the right point of your retina. So when you receive the visual information, your cranial nerve 3 nuclei both communicate with each other, and this allows both of your eyes to look in at each other, so both of your medial rectus muscles can contract at the same time. Then, for your pupillary constriction, as we discussed just now, your Edinger-Westphal nuclei will communicate with each other and close. And for your lens to fatten, again, your Edinger-Westphal nucleus plays a role in that it sends information to the ciliary ganglion and ciliary bodies, which pull less tightly on the lens and allow it to pull in closer. So next we'll talk about our medial longitudinal fasciculus. And this essentially is a neuronal tract that allows you to do conjugate lateral gaze. So this means that both of your eyes, for example, are focusing on something on the right. So this means, if you want to look right, that on your right eye, your lateral rectus has to contract, at the same time as on your left eye, your medial rectus contracts. So, as our lateral rectus is done by our cranial nerve 6, and our medial rectus is done by our cranial nerve 3, we need these two to be able to communicate across the different sides. So the way that we do this is by having on this diagram here this medial longitudinal fasciculus which connects cranial nerve 6 to cranial nerve 3, and this then cranial nerve 6 sends its information to lateral rectus on its side, and then cranial nerve 3 to medial rectus on its side. So in this example, on the left hand side, cranial nerve 6 is looking laterally, cranial nerve 3 is looking medially on the right hand side, so both eyes will look to the left. So next is the vestibulo-ocular reflex, and this is begun by a vestibular system. So when you look to the right, your eyes will typically stay focused on the object you were looking directly at for a moment before then flicking to the right once you've finished looking. And this is so your vision isn't blurred and focusing on random things as you look across. So as you look to the right lateral semicircular canal in your vestibular system will detect that you're looking right, and this will send information to its cranial nerve 8 nuclei. The right cranial nerve 8 nucleus will then communicate with the cranial nerve 6 nucleus on the left-hand side, and the cranial nerve 6 nucleus will then make you want to look left with your left eye, and will communicate with the cranial nerve 3 nucleus on the other side, also allowing it to look left. So that's the information comes in from the right as you start to look right, and this allows your left eye to look laterally, so look left, and your right eye to look medially, so that will also look left. So your eyes stay focused on that same point as you turn your head away. The way I like to remember this is if you think of a ballerina doing a pirouette, they'll stay focused with their eyes on one point on the wall for as long as they can whilst they turn, and then they'll look away eventually once they're facing the other way, but they try and keep their head focused on that same point on the wall for as long as they can. So if you have damage to your vestibular nuclei, then this can mean that you're less able to look in different directions because of this reflex. So typically your left hand vestibular nuclei, for example, will communicate with your cranial nerve 6 on the other side and your cranial nerve 3 on the same side, allowing you to look right. So if we have damage to this vestibular nuclei, this means you're less able to look right, and this will cause your eyes to drift to the left. Your body then realizes that your eyes are drifting to the left and flicks them quickly back to the middle. So the way that I like to remember this also is that if you have a problem on the left-hand side, then your eyes slowly drift to the left as if they're trying to find out what the problem is on the left-hand side, and then your brain tells them to flick back looking straight because it doesn't want them to know that there's a problem there. So this is called nystagmus, where the eyes drift slowly and then flick back to the middle. And in the example here, where you're drifting left and then flicking back quickly to the right, this is called a right nystagmus, because the fast phase is the one that it's named after. Despite the fact there's a problem on the left, it's called a right nystagmus because they flick quickly back to the right. So that's everything for this half of the cranial nerves, and then in the other half I'll explain what the other 7 cranial nerves do. Thank you.